Today's lecture will be given by Dr. John Van Anker, who is the Chief of Pediatric Clinical Pharmacology and Vice Chairman of Experimental Therapeutics at Children's National Medical Center. John is trained in pediatrics and neonatal medicine and holds a PhD in clinical pharmacology. Prior to joining Children's National, John worked at the Sophia Children's Hospital from 1984 to 2001. Currently, John supports several programs in pediatric clinical pharmacology and divides his time between Washington, Baltimore, Rotterdam, and Basel. John has published over 350 peer-reviewed papers in the field of neonatal and pediatric clinical pharmacology and is currently the president of the American College of Clinical Pharmacology. We know you will enjoy today's lecture.
Hi, my name is John Van Anker. I'm a pediatrician neonatologist, and I would like to the coming hour to talk about developmental and pediatric pharmacology to let you understand how children are different from adults. So this slide, what you can see, it's a busy slide, but I'm going to walk you through it because it's important to realize when we give medications to adults but also children, we talk about pharmacokinetics. In other words, you give a drug to a patient and what's going to happen with the drug. In other words, what the individual will do to get rid of the medication. Then we have pharmacodynamics. You give medication to a patient for a purpose. The patient has pain. So what you want to reach is pain relief. So pharmacodynamics is actually everything the drug is doing to the human body. Most of the time, of course, we give medications to patients who have a disease. And the disease might change the pharmacokinetics and the pharmacodynamics of medications. In the long run, we have two goals. We want to see an effective medication with no or minimal side effects. And that has to do with the clinical outcomes. A chance to go back in history is always, I think, very important. And this is a picture showing you the historical drug development in children. You see here in the middle, Cobb's baby's friend. It's against colic, diarrhea, cholera and teething, and it contains 8.5% alcohol and quite some morphine. In the same time period, there was also Todd's teething cordial. What you can't read probably, but in the lower part of the slide, it reads, satisfies the baby, pleases the mother, gives rest to both. Very noble goals, but the issue was that the rest to both meant for the children death. Another historical development was sulfanilamide. Many years ago, we had problems with the appropriate formulations. In 2017, yes now, we still have problems with the right formulations for children. On the left side of the picture you see sulfanilamide, a very good antibacterial agent, but there was nothing available for children. A very smart chemist then decided to add diethylene glycol to the medication to make it an elixir. Clearly the drug was still very good, but the elixir killed both adults and children because it's the same material you will put in your car in the winter to prevent it from freezing. On the right side is chloramphenicol, still used in many parts of the world to treat severe infections. And this was also given to newborn babies, but without thinking that perhaps newborn babies have a different way of handling medication. What happened? These kids were indeed less able to handle the medication, they got cardiovascular collapse and they died. And the whole issue was, of course, that these misadventures in children led to the creation of the Food and Drug Administration that helps a lot adults like us, but still not that much children. So when we think about children, these are just two pictures of critically ill infants. On the left side you see a child with a congenital intestinal obstruction. In other words, the baby needs surgery, otherwise there's going to be big pain and also big problems for the child to survive. The other child on the right side is a little bit older and got a severe infection. And if you look very well at the right leg and the left leg, they're very much compromised. In the long run the baby survived the infection but lost both legs because of the disease. Major things. Other things we're treating nowadays are these very small babies. Born instead of after 40 weeks, that is a normal age, these born after 23 weeks, and you can see the size, the hand of the mother is there. A baby with a weight of 500 grams. So huge differences in weight in these children, and clearly also huge differences in what kind of medication they need. So when we then think about determinants of drug response in infants, The red bar makes it very clear. It's growth and development. Why is it important? Because you have a moving target continuously, and when you hit the moving target in the wrong moment, it can have lifelong consequences. So the responsibility of treating patients, young patients, with medication is quite large. The lower part of the slide shows you what happens with the medication, but I will come back on that in my presentation with real practical examples to make you all enthusiastic about pharmacology in children. In addition to normal growth and development, I mentioned earlier disease already. Of course, we don't treat healthy individuals. We treat patients with diseases. And diseases have an impact on growth and development. Environment is important. Think about babies fed formula or breastfeeding. It will change their life forever because the intestinal metabolism is completely different, not only in the newborn, but even in you today. Then finally, I will also in my presentation give some information about genetics, because nowadays we are 10 years or more already after the genomic area was discovered, but in children we're quite far behind. But I give you some real clinical examples that it's important in children too. So what is the challenge of working in pediatric clinical pharmacology? It's to determine the sources of variability. And this slide shows you the two main players, the key players. On the left side, ontogeny or developmental changes. On the right side, pharmacogenetics. And the right picture shows you actually 4 girls of 12 years of age. And without much imagination, you can see some of these girls are still girls, and some of these girls of 12 are turning into young ladies. So when you think about doing drug medications with drug research in children, just looking at age is not the right way to do it. You need to look really at the developmental stage of these individuals. Critical role of pharmacokinetics in pharmacotherapy. Why is it in children still so important? In adults we don't want to hear about it anymore. It's because the combination of absorption, distribution, metabolism and elimination will dictate the exposure to the medication, and that will dictate the dose we want to use. Let's start with absorption. Many factors play a role in oral drug absorption. And again, I have no time to go to all these issues here, but splenic blood flow is important, gastric pH, intestinal drug metabolism, intestinal surface area, intestinal drug transport, microbial colonization, intestinal motility, gastric emptying time, and biliary function. In addition to that, also biopharmaceutical interactions will play a role. Today I only want to give you 2 examples, one about gastric pH changes and also about gastric emptying time changes. So this is a slide showing on the y-axis adult activity, on the x-axis gastric acid production, pepsin production and gastrin production, but for today I'd like you to focus only on the first part. That's the gastric acid production, and what you can see here clearly, when you go from birth on the left side of the slide to adulthood, there are changes in gastric acid production, and in the long run it will be an increasing capacity. Is it important to know for you? Yes, it's important, because the next slide will show you that when you give oral medication and you don't realize that this is the difference in gastric pH, things will change. This is the old slide from 1953. So also for young people who listen to the presentation, never think that before 1980 not important things were published. So it's very worthwhile to look at these things. So on the y-axis we see penicillin concentration. On the x-axis the hours after the oral administration of 1 dose. And what you can appreciate here is that preterm neonates and full-term neonates, both the blue and the pink lines, still have capacity to absorb the medication after oral administration. But as soon in yellow and in blue you get older than 2 weeks of age, the problem will appear that you don't absorb it anymore. This is important to know, because when you treat patients with oral medications and you don't realize this, some of them will be treated, some don't, and when they don't improve, you don't know where it's coming from. Changes in gastric emptying time. This is a busy slide, but I'll walk you through this one. On the y-axis, the percentage of the meal. On the x-axis, different postnatal ages. And this looked at 30-minute gastric retention. In other words, you give a feeding to a child and 30 minutes later you check how much is still in the stomach. The light bars are preterm infants, the dark bars full-term infants. I like to focus today only on preterm infants. Between 4 and 12 hours of life, 60% of the meal is still in the stomach. When you look at 46 to 60 hours, only 40%. So in just a couple of days, preterm infants even are able to move the bowel easier, get easier the gastric emptying done. And when you think about medications, they need to be absorbed. So giving it in the first hours of life will have a different impact than later on. I give you an example of this one too to make sure to you that you don't think that's just theory. So this was a study done some years ago looking at Cisapride, a medication that was used for gastroesophageal reflux. And I made only for you clear what you need to look at is the yellow part, Tmax. In other words, the time you reach the maximal concentration. 3 different groups post-conceptional age-wise. Children between 28 and 36 weeks, 17 of these. Children between 36 and 42 weeks, 13 of these. And then 5 kids between 42 and 54 weeks. And what you can see here is that younger kids have a longer Tmax than older kids, indicating indeed that also in addition to the gastric emptying time, also the intestinal transport is changing. Important to realize when you use medications orally. Then we have other ways of giving medications, extraoral drug absorption. Of course, many factors play a role there too, like regional blood flow, temperature, diffusional surface area, hydration, tissue binding sites, local pH, and drug vehicle interactions, and finally barrier thickness. I give you just an example of barrier thickness to remember this much easier. This slide shows you developmental changes in skin thickness. On the left side of the picture, you see a child born after a gestational age of 26 weeks. As I mentioned earlier, normal is 40, so this child is born more than 3 months early. And this skin is looked at as the first day after life. Postnatal age is written there, 1 day. You can see there's hardly any stratum corneum. In other words, you put something on the skin, it goes immediately into the system of the baby. The same baby 2 weeks later has developed a beautiful stratum corneum. In other words, where you put something on the skin there, nothing goes through or very limited. And that skin is comparable with the third picture, a child born on time in the first day of life. So something magical happens. As soon as you get born, the maturation is much faster. So a child born 3 months early, 2 weeks later already has the same skin as a child who has been staying 3 months longer in utero. So I think that's important for clinical practice. So distribution is the next factor, and what you can see here on this slide is the impact on development on drug distribution. On the y-axis, the percentages, on the x-axis from birth to 40 years of age. The green line shows you the changes in total body water, the red line is the changes in extracellular water, and the dotted line the changes in body fat. We know more details nowadays, so this slide shows you in orange extracellular water compartments, in green intercellular water compartments, in gray protein, and in blue fat. And from top it's premature babies, then the full-term babies, and then we go on from 4 months to adulthood. And what you can see in this slide is when you're premature born and you take together extracellular water and intracellular water, that almost 90% of the newborn baby is water. You can compare it with a jellyfish, so to say. And when you get into adulthood, much more compartment is going to be fat and other issues, and you can, depending on how heavy the fat compartment is, you can compare these individuals with calamaris. That's to remember easy the differences in these body composition. Is this important? Yes, it is. I just give you one example. Amikacin is a drug that is used many times. It's like Gentamicin or tobramycin, and it's an antibiotic. And already in 1993, Jean-Paul Langendries published this paper, and I want you only to look at the bold part, the volume of distribution. Remember the orange bars I just showed you. So when you're less than 28 weeks gestation, your volume of amikacin is 0.7 liters per kilogram. And when you're term, it's 0.5 liters per kilogram. And what is important to realize here is that indeed what we saw with the orange bars is reflected when you give medications to children. Why is this so important? Because the next slide shows you but gentamicin, so the brother or sister of amikacin, that when you want to reach an appropriate peak level, you need to give more of the medication to the younger children. And this shows you that 1993 was a former slide showing that it takes 10 years or more to change clinical practice. Because between brackets under the dose milligrams per kilogram, you see still 2.5 to 3, whether the child was less than 29 weeks, 30 to 33 weeks, more than 34 weeks, in the first week of life, in the first days of life, it didn't matter. So finally in 2005, we doubled the dose based on the information that was already available in 1993. Important to realize that not only translational research is going from laboratory to patients, but also if we discover things in patients, how do we convince our colleagues to listen to that? So then we go to metabolism. Metabolism, we always have been told that it is primarily the liver. That's correct, but there are also other sides of drug metabolism. The brain metabolizes, the lung metabolizes, the skin does it, and the most important other organ that does this kind of work is the gut. So for certain enzymes, the gut has 50% of the activity. So please remember when you go home today that liver is important, but the gut is at least as important for metabolism. So what do we know about drug biotransformation? When I give a drug to a patient, there's a phase 1 step, determined by cytochrome P450s and other enzymes that results in a metabolite that sometimes can get excreted, but most of the time, for most medications, we need a phase 2 step. The UGTs, the NETs, the STs for sulfotransferases. And why are these enzymes there? Because then you have a metabolite that can be excreted by the kidney, so it comes to the urine. Crucial to remember that whatever age you have, it's important to have proper working kidneys. Especially when you're younger than 2 years of age, it's crucial. You can have a perfect liver, a perfect intestine, a perfect brain. If your kidneys don't work, you can get rid of the medications. So what do we know about it? This is a picture showing the developmental changes of one of the enzymes, 3A4. Important because it is involved in metabolism of 50 or more medications. This is published in 1997. And I want you to remember that because the next slide will show you the more modern ideas about it in general. On the y-axis again, percentage of adult value. On the x-axis I like you only to look again about the activity. And what you can see from the left to right is the fetus less than 30 weeks, a fetus more than 30 weeks, then children born dying in the first day of life, and then babies dying in the first week of life. What you can see here is change in capacity of metabolizing these enzymes. This is all done with microsomal work in the children who passed away. This is 2008. Ron Heinz, who is the main author of this paper, dedicated 25 of his career on deciphering this. And it's important. It shows human hepatic drug metabolizing enzymes ontogeny. And he decided to divide them in 3 classes, class 1, 2, and 3. In class 1, I'm only mentioning one, cytochrome 3A7, the second in a row there. That's one that's important in fetuses. Class 2 is 2C19, important for proton pump inhibitors. I come back at the end of my presentation in the genetic part about cytochrome 2C19. And then class 3, many enzymes, so by far the largest class, having both cytochromes but also parts of the phase 2 enzymes. And why did he decide to do this? On the y-axis here you can see the drug metabolizing enzyme activity. On the x-axis 4 different groups. Children with a gestational age between 10 and 26 weeks, children between 26 and 40 weeks, children with a postnatal age between 0 and 6 months, and children with a postnatal age between 6 months and 18 years. And what you can appreciate here for class 1 is that there is more activity in utero than after being born. Then class 2, you can see there's some variation in the different time frames, but no big relationship. Whereas then in class 3, again, the largest, there's hardly any activity before you're born, and after being born, it becomes very active. Of course, all these differences in enzyme activity were not designed this way for us, but we're using that knowledge now to really look at how we can handle medications better. Clearly, we always need to translate what is found in microsomes to real life, and this slide shows you on the y-axis the clearance of midazolam, used for sedation in adults and children, and on the x-axis birth weight. And what you can see here is when you get larger, the clearance will go up. But you also can see here is that there is a huge variation in the different weight categories. Why do I show this slide? Is because when you work in your unit, think about these things. You give the medication to children. We don't know much about these. Sit together with pharmacists, with geneticists, with parents, and talk how you can get information out of the medication, you're already giving to patients. And this is just an example. We know that midazolam is metabolized to 1-hydroxymidazolam and 4-hydroxymidazolam. 1-hydroxymidazolam by 3A4, 4-hydroxy by 3A4 and 3A5. So when you just design a study and you also take the effort to look at the metabolites, you will learn so much about the developmental changes in these enzymes. And I mentioned earlier, 3A4 is important for 50 or 60 medications. Another example is Cisapride, a medication used, earlier said already, for reflux. And this is also, 3A4 is the most important enzyme to metabolize Cisapride to Cisapride. So we did a study in the network again that did a single-dose kinetic study in newborn babies and young infants. You remember this slide because I showed you earlier Tmax when I talked about the changes in oral, in gastric emptying. And now I would like you to look at the lower part of the slide, clearance. So when the microsomal work is correct, we like to see that it also works in real life. And what you can see here is that clearance is 0.45 for the youngest children, 0.75 for the children in between, and 0.85 for the oldest. So indeed, for cytochrome 3A4, it seems to be that the work done by Ron Heinz is reflected in real clinical life. Not always it's so easy. This is an example just to make you aware that if you're going to use medicines in children, study them. Because without studying them, you can make major mistakes. This is a drug called Linezolid. It's a drug used when you have vancomycin-resistant bacteria. In other words, there's nothing available anymore to save the patient. So you're going to use this medication. Without this study, and I'm going to underline now the importance, you can see that adults have a clearance of the drug of 0.1 liter per hour per kilogram, children 0.3 and infants 0.52. In other words, intuitively you would think that children always have less activity, less clearance. In this case it's the other way around. Infants have a much higher clearance. Think about this drug. It's against bacteria. So when you wouldn't know this and you would give the same dose or a lower dose intuitively than in adults, these patients will all die because you don't give enough. And we would say the drug is not working in children. So these studies are crucial. I give you 2 more slides to even show you how weird this medication behaves. This slide shows you on the y-axis the clearance of the medication, on the x-axis again the post-conceptional age, and there are 4 groups. Open circles are preterm infants, less than 8 days of life. Open triangles are the term infants, less than 8 days of life, and then we have the closed circles are the same preterm infants after the first week of life, and the closed triangles, the full-term infants after the first week of life. And what you see on this slide already is that clearly in the first week of life it's all lower, but after the first week of life it doesn't really matter that much. And the next slide gives you more details. Clearance again on the y-axis of the same medication. On the x-axis not post-conceptional age but postnatal age in days. And what you can see here, indeed, it's lower in the first week of life, but after the first week of life, it doesn't matter if you're born 4 months early or on time, you have the same clearing capacity. We really don't understand still now why this is, but without doing the studies, we would dose completely wrong, and now the dosing advice we have for this medication works perfectly for both adults and young premature infants. So you can see the rapid changes in these patients. The other factors that play a role in metabolism. Herbal medicine, it depends where you are in the world if herbal medicines are used by parents or parents giving herbal medicines to their children. Not many of us are asking about it. Important to do though, because it has a lot of potential impact on how you handle medications that you prescribe. Disease, I come back on that later in my presentation. Drugs there, of course, when you take one medication or you give one medication to your patient, there's no more interactions. As soon as you add another medication to that, there will be interactions. And if you add the third or the fourth, you're asking for problems, but you don't ask for problems. You need the drugs to treat your patients, but you need to be aware of that. Then genetics I come back on later. Age I show, and then nutrition is there, showing this nice grapefruit juice on the right side. And the issue is that when you have medication on board and you take grapefruit juice thinking it's healthy, it potentially can kill you. Not because grapefruit juice is bad, no, but it inhibits a lot of these enzymes that I talked about earlier. And when you then have medications depending on these same enzymes, you suddenly get with the same dose much higher concentrations that can lead to horrible side effects. I'm going to give you now the example about the disease. When you think about inflammation and drug metabolism, we know more and more and more. So what's inflammation? Can also be infection, can be trauma, can be surgery, can be cancer. We know all these factors result in increases in pro-inflammatory cytokines. That will result in a decrease of the cytochromes. In other words, make the link. You have infection going on or inflammation going on, and your metabolizing capacity goes down. In other words, what happens is like eating the grapefruit juice. The exposure with the same dose will go up, and the chances of side effects is dramatically going up too. This is something not many of us think about. When you're in the intensive care and you get medication against pain or to sedate you, we're not thinking quickly to give only 10% of that medication if there is infection. So when the hypotension that we link to the infection persists, we need to start thinking that it might be because of overdosing of our medications. So cytochrome 3A4, we mentioned it earlier. I showed you this slide from Ron Heinz and also from earlier. But this is also important again, as I showed you before, for midazolam. Therefore, in adult medicine, midazolam clearance is already used for 3A activity in patients at the intensive care, just to measure how strong the metabolism is. That's published in 2010. In children, we always a little bit later, but I give you the most recent data that was just published in 2016. This slide shows you the impact inflammation. On the y-axis, you see the predicted clearance of midazolam. And on the right part of the slide, what you can see is the CRP, and CRP stands for C-reactive protein, a measure of the severity of inflammation. 10 is the lower severity in this case. Normally, you and I will have less than 1. 32 is more inflammation, and 300 is severe. And what you can appreciate from this slide is that, of course, based on body weight also, but when you're going to get more inflammation, the clearing capacity goes down. And of course, I showed you before that getting older, getting higher body weights increases it. So there's a delicate balance between increase based on maturation, but then a dramatic decrease based on being ill with an infection. There's more to come. Because also when you get sick, not only you get more inflammation, but some of your organs don't work, like your liver or your intestine or your kidneys. And we know that if you look at this slide again, I showed you the top part earlier, but then you look at the lower part, organ failure, 1 organ failure, 2 organ failure, 3 organ failure, more than 3, you see that the clearing capacity even goes further down. So these patients are going to be hardly having any capacity to metabolize the medications. So when we combine this, it's not that we talk about 5% changes. No, just getting ill, severely ill, results in major changes. This is minus 35% in the different lines that I put there. And you can see clearly that sometimes it goes rapidly down every time and hardly any capacity is left. So we really had to start, and this just published last year. Most of us don't know that yet, and I'm sure many in the room won't know, but now you know. Start thinking about it when your patients are very ill. So to summarize, the 3A mediated clearance of midazolam in children is dependent on 3 parameters. Maturation will make it more quick, so you have more capacity, but when you have inflammation or organ failure, it will change. And this is midazolam as an example, but of course it has implications for all the other 3A substrates, something to really take home today. So then elimination, the next step, of course, this is a slide showing you the maturation of renal function from, on the x-axis, the first 2 days of life till 12 years of age. And this is an old slide again, but it shows you the changes in kidney weight, the changes in glomerular filtration rate in red, the changes in kidney length in blue, and the changes in renal plasma flow in yellow. And you can see their changes are there. Some are more dramatic than others. But from this slide, you don't appreciate how quickly the changes are in the first month of life. And this slide makes you that more aware. What you can see here on the y-axis, the glomerular filtration rate, so in other words, renal function. And on the x-axis, kids between 1 and 2 days of age, 8 to 9 days of age, and 15 and 16 days of age. I want you only to look at the green bars because these are the term infants. So in the first days of life it's 30, a week later it's 50, a week later it's 70. So when you think about newborn babies being defined as being the same in the first 28 days of life, this slide shows you that they dramatically change in their renal clearing capacity. So when you treat a baby in the first days of life for an infection and you dose an antibiotic with a certain dose, then you have to realize that you might overdose. The same baby gets ill 2 weeks later and you want to use the same dose because it's still the same newborn, surely you're going to underdose because the baby has more than twice the capacity to get rid of the medication. Important to realize. This is just an example showing that for a drug called ceftazidime, there's other antibiotic treatment, and the y-axis is total body clearance, on the x-axis is the gestational age of patients, and this was all studied on day 3 of life. There is a dramatic increase in capacity in these children throughout gestational age. So the longer they stay in utero, the higher the capacity when they're born. Coming back on that slide I showed you earlier, I made bold the dose milligrams per kilogram, if you surely remember, the major step from 2.5 to 5 between 2002 and 2005. Of course, when we go up with dosing to reach a good peak level and to kill bacteria, and I just showed you now the renal impairment, we have to realize that also the dosing interval needs to change, otherwise you're getting that toxicity. So between brackets on the bolded part, that was what we did in 2002. Between every day, 24 hours, or 3 times a day. But when you give much more dose, you have to be going to probably once every 2 days, and now we think even sometimes for the youngest children, every 3 days. So we have to really think about these things together. You as clinicians can't have this all alone. You have to work with the pharmacist, with the pharmacologist, and other colleagues to make this optimal for your patients. So to summarize this part, I think I have trying to show you that there are differences in extravascular absorption rate and extent, that altered body composition will influence distribution. I showed you this bar, the orange bar, showing the jellyfish and the calamaris. That there is a marked ontogeny or development of drug metabolizing enzymes, and furthermore that there's also a dynamic influence of development on renal function. Not that slow as we saw in the past, but really rapidly already in newborn babies. So let's then go to the other part of my presentation that will be not taking that much time, but I think it's important for you all to know that genetics play a role even in the youngest individuals. So what do we know about pharmacogenetics? Realized it in 1957 already by Friedrich Vögel, a German colleague. He already defined it with the study of the role of genetics in drug response, and that definition 60 years later is still very, very valid. This is just some history, no time to go over it, but realize that there are some important milestones in the history of pharmacogenomics. 1866, Mendel lays down the principles of heredity. And it took till 1982 before Michael Algebaum in Germany started to link all this genetics with how people handle medications. And nowadays, of course, we have the PCR, we have all kind of opportunities to do so. So I'm going to give you 2 examples of enzymes that we know something about, that are easy to remember also for you and are important. Cytochrome P450-2D6, so not 3A4 by 2D6. Just when you think about EM stands for extensive metabolizers, PM for poor metabolizers. So what happens? You give a medication that's a substrate for 2D6. When you're an extensive metabolizer or wild type, normal, you will make stable metabolites and you will excrete this medication. When you're poor metabolizer, the same medication, same dose, will result in accumulation because you are a poor metabolizer. So you will make less metabolites and you will excrete less. So these patients act like having a functional overdose. Not because you and I made a mistake, that happens too, tenfold overdose, but this is because the father or mother of your patient didn't give the patient this material. And of course the parents didn't know that, and this is also all just to remember that genetics plays an important role. So what do we know about 2D6? We know that in Caucasians there's a bimodal distribution. I will show you that later and also graphically. 5 to 10% of Caucasian population is deficient, so these people don't have activity of 2D6. So when you then give a drug that's dependent on 2D6, they can't get rid of it. And so these poor metabolizers, or PMs as we call them, have 2 inactive forms of the gene. And these people are indeed at risk for concentration-dependent side effects with normal dosing. And some drugs may not work, so codeine needs to be metabolized by 2D6 to get morphine out of there. And for tramadol, needs also to be metabolized by 2D6 to make the active metabolite. So if you don't have 2D6, you can give them a kilogram of codeine or tramadol, it's not going to work. So this is the bimodal distribution from Caucasians. On the y-axis, the number of tested individuals. On the x-axis, CYP2D6 activity. To the left, it's faster. To the right, it's slower. And what you can see indeed, that there is this second hump on the right side that makes the lower metabolism. We know a little bit more nowadays, and I will show you that in the next slide. What you need to realize is that when you treat patients, it depends where you live, but I live in Washington DC, multiracial, multi-ethnical, very diverse population, very interesting, wonderful to live. But you have to realize that if there is a Chinese person sitting across you who wants medication, that these people are in general a little bit more slow than the Caucasians with the bimodal distribution. And I don't have the slide with me, but when you look at African Americans, they're even more slow. So we think about the African American patients with sickle cell disease. How long have we been trying to treat them with codeine? They were always deemed to fail. And of course we started to blame them that the codeine was not what they wanted morphine. They didn't get good treatment. And this knowledge helps with that. So we know more. This is a lot of data from Europe. But in addition to extensive metabolizers and poor metabolizers, we have also intermediate metabolizers, and on the left side, ultra-rapid metabolizers. And I'm going to give you an example why that's important. This is a case report already more than 10 years ago, but I think very illustrative. Lancet paper is quite well respected, like the New England Journal in the US. It was a full-term healthy male infant. Both parents were physicians and saw a physician every day because they were very nervous. It was the first child. On day 7 after birth, there were intermittent periods of difficulty in breastfeeding. That can mean everything, that can mean nothing. On day 11, the baby had regained his birth weight. That's very reassuring. That's what you want between day 10 and day 14. But then, of course, day 12, gray skin, milk intake had fallen. That was very ominous. And then a day later, the baby was found dead. A horrible story. Both parents very, very vigilant, went to doctors, and this happened still. So the autopsy was done. There was no abnormality. And the coroner was very active. He was measuring all kind of, trying to find reasons why the baby passed away. And what he found was very high levels of morphine, 70 nanograms per milliliter. When you or I would have 70 nanograms per milliliter, we will stop breathing too. So normally it's 0.222. So what's going on? So they were worried that the parents gave the patient something. So then we go back to pharmacogenetics of codeine. I mentioned codeine is metabolized by 2D6 in the liver to morphine. Then morphine goes to the blood-brain barrier, to the mu-opioid receptor, to give pain relief. Already a long time ago, 1998, in healthy volunteers, the studies were done to give codeine to poor metabolizers, that are the white dots, and codeine to extensive metabolizers. And what you can appreciate here, on the y-axis is morphine concentration, in the x-axis time. After the same dose of codeine, when you're poor metabolizer, there's hardly any morphine produced, fitting with the poor metabolism. When you're extensive metabolizer, you make quite some morphine, between 20 and 40. So what is the conclusion of this case? This was happened. Mother had pain after a very painful procedure during the delivery. She was prescribed codeine and paracetamol by the Canadian physicians every 12 hours, so twice a day, for 2 weeks. To make a long story short, in this time we could do genotyping of the mother. So it was discovered that the mother had a gene duplication. So it was not because the parents give the patient something to die from. It was because the mother had a genotype that made out of the codeine so much morphine that the baby got it through breastfeeding and passed away in that reason. This case led to a big warning from the FDA to not use these medications during breastfeeding. And actually, most recently this year, the year before, the FDA actually banned codeine use in all children, also because of the risk for decreased breathing. So I think very illustrative that genetics, genome, is very going to be important to help us understand what happens in some horrible cases. Then 2C19 had promised that also it's important, and it's more recent. In 1984, a very observing physician saw unusual sedation in a subject receiving this anticonvulsant. And they discovered that it was indeed based on genetics. A mutation that was only affecting 2 to 5% of Caucasians, but 20 to 25% of Asians. And drugs involved are omeprazole, lansoprazole, pantoprazole, diazepam, and it can have major consequences. And I'm going to give you just an example to show that it is not as easy again as the 2D6. This is a picture showing you on the y-axis elimination rate constant, Ke. On the top is faster, on the bottom is slower, and on the x-axis is 2C19 activity score. In other words, linking genetics to the phenotype of the patient. And when you have on the right side the star 17 mutation, that's the highest activity you can get normally in 2C19. And I put it there, drug X, because I'd like you to focus still to the end of my presentation. Lack of association between 2C19 activity score and the elimination rate constant, something that surprises you, because when you really increases 2C19, you count on also an increase in clearing capacity. In this case, it didn't work. Then we go to drug Y. Same picture on the y-axis that showed you the slower and faster. Again, the activity score on the x-axis. And when you look now to the star 17, it's still a star 1, that's normal, but star 17, you can see there is an increase in clearance of this medication that fits much better with our logical thinking about 2C19. So what's the explanation? This is the explanation. You need to know the drug very well. So the left drug is omeprazole. That's a proton, one of the first, actually the first proton pump inhibitor. This slide is busy, but I want you only to look at the red, big red arrow and the big blue arrow. 2C19 is there, but what you can see in omeprazole, that 3A4 is also important. So when 2C19 has been changed, the 3A4 is still able to metabolize omeprazole very well. So therefore, there was no real effect. When you look at pantoprazole, the other medication, you can see that the CYP2C19 is much more important. So when you're going to change that genetically, then it has a big impact on how you handle the medication. So again, showing that no physician alone, no pharmacist alone can do this work. You need to make teams, otherwise you're not going to improve the care for your patients. So, tip of the iceberg, I wanted to show you today what we know a little bit. But when you realize we know a lot about drug metabolizing enzymes, but what is also important is that we know a lot about what we don't know. So transporters, receptors, the normal development of these things we don't know yet. That needs to happen in the coming years, and most of you listening are much younger than I am. That's your future. There's a lot of work to be done. Don't think we know everything. We know a little bit. So in the long run, the most important thing is, of course, to have target therapy, even for the youngest individuals. And for that, again, and I repeat myself several times, you need teams. No one of you in the room can do it alone. No one of me, my colleagues and myself can do it alone. You can forget it. So before I'm going to finish up, I think this is always important. This is a quote by Paracelsus. His name was much longer, as you can see, but we all know him as Paracelsus. That all substances are poisons. There is none which is not a poison. The right dose differentiates a poison from a remedy. I'd like to thank you very much for your attention. I think that I hope I give you an idea that indeed children are different from adults, also when you give them medications. And I want also to tell you that if there are any questions about the course, please contact the program coordinator at the NIH, and they will have answers to that, but they also will be able to reach me, and they will be always willing to support whatever questions you will come up with. And I hope this helps you in your clinical practice for many years to come.